Foundation. And we are so happy to have you with us today, Dr. Garcia.
Hi, good afternoon. It's nice to be here and thank you for the invitation.
Excellent. And I guess to start us off, could you tell us a little bit about what the standard of care for high-risk MDS is currently?
Yeah, thank you so much for this question. For patients that are diagnosed with a high-risk MDS, some of the workup that we include on a regular basis and that I do recommend and is supported by guidelines would be to have a set or series of hematologic labs, to have some basic chemistries to understand organ function. And then, of course, importantly, to get a bone marrow biopsy. Still to this day, we use morphology. Morphology means the shapes or how things look under the microscope to make a diagnosis of myelodysplastic syndrome. This diagnosis does require pathology to review the bone marrow liquid aspirate or core biopsy slides, and that often requires some expertise as to not miss it. There are some definitions that currently the pathologists use in order to qualify a person for having a myelodysplastic syndrome. As a part of that bone marrow biopsy workup, we send out a few additional things. We send out something called chromosomes, and that's when we take a look to see if there's any abnormalities among the chromosomes that we have and sex chromosomes as well that we inherit from our parents. And what we do is try to identify are they normal or abnormal? And if there are any characteristics of them that suggest that it would cause a higher risk or more advanced myelodysplastic syndrome. And it also could suggest therapeutic vulnerability, meaning it could potentially sensitize patients if there are certain chromosomal abnormalities, 5q deletion being one of them. And there are also mutations that get sent out. So if someone is evaluated at an expert disease center where they see a lot of MDS, it's pretty standard of care and often done on site, where they'll send a myeloid, which means the type of white blood cell cancer that we're discussing here, a myeloid next generation sequencing or mutation panel that's dedicated. And that's really helpful because it tells us about risk classification, meaning um, how likely it is that this patient will have development of acute leukemia, and risk classification that informs us what types of treatments are appropriate. It also tells us whether or not transplantation should be recommended. And also it gives us information about prognosis. What is the survival expected for the patient, and how do we manage this disease or illness given that expectation? So I would say that in terms of the standard of care right now, it does include labs, a physical exam, and a bone marrow biopsy. I would say that one of the things that we're doing better is now that the access or ability to obtain mutation assessment is getting a little bit easier at places that are not high volume or large disease centers. It's allowed us to capture patients who are evolving into an MDS. So there are precursor syndromes where it's not quite MDS yet, but there is a chance it could develop in the future. That includes conditions like clonal cytopenias of undetermined significance. That's called CCUS. That can often occur years or even decades before MDS occurs. Not all patients with CCUS develop MDS, only a small proportion, but we're getting better at identifying mutations. It's becoming something more accessible. And so now we're picking up and identifying patients that need to be followed in a hematology clinic. In terms of things that we do, I would recommend after a bone marrow biopsy that it gets also evaluated along with the patient at a tertiary care center or a place that sees a lot of MDS. For most patients with MDS, thankfully, not all, for most, the disease is not as rapid as it is in acute myeloid leukemia. So often there's time, meaning a couple or a few weeks, for a patient to seek a second opinion at a disease center in case their place where they got diagnosed does not see a lot of MDS. And I do recommend that patients get that if it's possible or affordable, and to see if this distance is an issue, if a virtual visit is available. I think gathering intel is really important so a patient knows what their options are or if they got the right workup done. If it's possible, I would also have that bone marrow biopsy evaluated at the expert disease center because often if you have a really good hematopathologist, now that's an expert pathologist that really only sees leukemia patients, which is really fantastic because they're so good at what they do with a microscope. They could even confirm, does a patient really have high risk MDS or are they really evolving into an acute myeloid leukemia already? And that is really informative for the action plan for the patient. So I would say in terms of recommendations, generally, I would, if it's possible for a patient to go to an MDS center, I would say that would be great if it's possible. I would recommend a bone marrow biopsy. Third, if someone is less than 75 years of age, I would recommend a transplant evaluation. I would say unless someone is completely against it, I would still get an evaluation to learn, is this something that they want to consider? Are they even a candidate? What does it mean? We'll get more into details about transplantation later, but I do think that's important. Generally, at transplant centers, that's where the MDS disease center will also be. So it's a time where you could do a 2-for-1 visit, meet an MDS disease expert plus a transplanter. And I would also consider if there is time and capability to do a genetics evaluation. Um, Genetics is the study of the genes. And so I'm not just talking about testing your mutations, which is the highest priority, but patients themselves can also undergo extensive family history and discussion to figure out, did this MDS occur because there was an underlying inherited predisposition? Most MDS cases are indeed spontaneous, meaning they just occur, quite frankly, because of bad luck or damage to their bone marrow compartment or the acquisition of a mutation that occurred over time. But there are a low number of patients, but it's not trivial, that where the MDS occurs because of an inherited problem. And that is important for two reasons. One is it can impact their family, their children, grandchildren. And so it's good for us to work this up to make sure we understand who this would impact in the family. And then secondly, it also can impact the patient themselves. If a patient, for instance, was undergoing a bone marrow transplant evaluation and the transplant team could not identify an unrelated donor and needed to go to the family to get a donor option, if there's an inherited condition, it could also put the patient at risk for getting stem cells from someone where they don't have the healthiest stem cells and that they might go on to redevelop their cancer again. So having this information is actually helpful. It is what I call extra because the first step is to get the basics. This would be the next level step for getting additional information. In terms of treatment, as of today in May 2026, the standard of care is still offering patients transplantation. And in terms of treatment, if they cannot get to transplant immediately or if they're waiting for transplant to happen, hypomethylating agent with azacitidine, that's Vidasa for brand, or decitabine, whether it's intravenous or given in the oral formulation of oral decitabine cytisiridine. That brand name is called Enquovi. Those drugs would be the standard of care for frontline MDS treatment if someone was not immediately moving to a transplantation.
Thank you. That was so incredibly clear and such a complex topic, so you answered that beautifully. Um, I did have a follow-up question to it. What are some lessons that have been learned from recent phase 3 clinical trials about higher risk MDS?
Yeah, so in the field, we've been working really hard and we are definitely not done at trying to improve the current standard of care treatment options that are available for our patients. When possible, we need to transplant to cure. But in the meantime, the median age of patients with myelodysplastic syndrome is in the 70s. And so not everyone is a transplant candidate. Now, if you're 70 years old, it doesn't mean you shouldn't be evaluated. In fact, you should. And there are disease centers that will transplant up to the age 75 and even some just above 75 too. So I think a consultation is worthwhile if someone is definitely less than 75 or someone is extremely fit as a 75-year-old. But in the meantime, for those that are above 75 or those that have not yet made a decision on what to do, um, the treatment for high-risk MDS is a hypomethylating agent, and those are the three drugs I mentioned before with azacitidine, decitabine, and the oral formulation of decitabine. Um, Over the last decade, we have really tried to overturn this, meaning to give something else instead. And that really has been focused on combination studies where there were randomized trials in the phase 3 setting. There have been several where we compared a novel combination where we gave hypomethylating agent like azacitidine plus a second drug versus azacitidine plus placebo. And placebo means you don't get the extra drug. Everyone got something. It's just that they didn't get the extra drug in one of the arms. Now, there have been several phase 3 studies, including drugs with venetoclax. That is an oral pill that is a selective BCL2 inhibitor, already FDA approved and given for frontline and relapse setting for acute myeloid leukemia. There have been really encouraging studies in the phase 1 setting or early clinical trial setting with myelodysplastic syndrome. And unfortunately, that did not meet the primary endpoint of improved overall survival compared to azacitidine alone. There has been another clinical trial with a TIM-3 inhibitor. This is an immunotherapy with sabatolimab. It was antibody-based targeting an immune checkpoint. And though that drug was found to be very safe, it also did not lead to improved survival. There was another drug called magrolimab, a CD47 macrophage inhibitor, where there was a lot of really extreme interest because of the biological activity being so novel and new. And unfortunately, that drug did not show improvement in survival and in fact showed futility, which means less of a good outcome compared to the control arm, which is what you never want to show, is that we didn't give something with extra drug. We in fact took something away. Some of the stuff that's been happening in the background with magrolimab is there's been additional efforts to try to understand, is CD47 the right target? And there was some really elegant work that came out of uh, Dana-Farber and the Broad, where they try to understand what the true target was. And they did find some differences between the murine or mouse models and the human models to suggest that maybe CD47 was not the right target as intended. And so we've done as much as we can in general when we get drugs from the lab to the phase 1 and then phase 3 space. But no model is as perfect as a human will be. And so when moving stuff from the lab to human, there will always be a limitation. And so we always have to move things to patients once we've confirmed safety and at least some encouraging activity and biological rationale, but there is generally limitations. And we don't find this often until we get it into a patient. One of the other drugs that unfortunately did not make it to approval was pevonedistat as well. That over 5 years ago was shown to not meet its primary endpoint. Pevonedistat is a netylation inhibitor. The way to think about that is it helps to target bad proteins for the trash can. And while all four of these drugs, as an example, there are a couple other ones like tamibarotene, um, did not meet the primary endpoint. And that means the goal of the clinical trial. Whenever we design a clinical trial, we decide what is the main goal for this study. There can only be one possible, because it determines what the statistics will be. Like, what do we need to prove in order to show that the drug really worked? And it also determines the number of patients that need to be treated in order to prove that point. And in the setting of all the studies I just mentioned, the primary endpoint was either complete remission, meaning bone marrow response plus improvement in blood counts. And the majority of the trials use the right endpoint, which is the gold standard, and that's overall survival. How do patients do and how long do they live compared to the control arm, which was azacitidine or Vidaza? One of the challenges that we have learned, getting back to Dalton's question now, after giving you this background, is that the control arm and what are our expectations? Azacitidine is a rather easy drug to give. You give it for about 7 doses or 5 days plus weekend off and then 2 days the following week. So still 7 doses every cycle, which is about every month. And the original study called AZA-001 over 15 years ago had demonstrated an overall survival of about 24 months compared to what they called conventional care regimens, which was either some low-dose chemotherapy or supportive care. Now, that 24 months, I got to say, is definitely not long enough by any means. I think that 24 months is still not enough time. But compared to the standard of care, which was supportive care or gentle chemo, it exceeded expectations. So that was the first win for myelodysplastic syndrome. But since then, it's been really hard to overcome that. And so that's one of the fundamental issues is we're trying to beat a control arm and the question becomes, is that really the right control arm that we should use? And how do we design studies? In trials over the last decade and a half, We really haven't been able to capture that same survival rate. It's been really more 18 to 22 months survival, not 24 months. And I know that sounds trivial, but then it becomes an issue when you're designing these novel clinical trials where you're trying to find a difference. We have yet, outside of transplant, which we'll talk more about later, have found a therapy that exceeds the 2-year overall survival. And that just tells us, about how difficult it is to treat MDS. It's a heterogeneous disease, meaning that it's built from a series of mutations and stem cell abnormalities. And so the stem cell compartment, which is the liquid part inside your bone marrow, is really abnormal. And so one of the challenges, I think, for reasons why these treatments failed is that, quite frankly, the drugs were not good enough. I think that one of the challenges we have in MDS is there are really two types of therapies, just to be very simplistic. We have drugs that get rid of blasts or excess blasts or leukemia cells, and we have drugs that are trying to target the stem cells, meaning like the early cells in development. We don't really have drugs that get rid of both completely in the MDS setting. The only thing that does that is transplantation. So one challenge really is the drugs in itself, is that when designing the study, you have to make sure you offer it to the right patients based on the genetic mutations and based on the amount of disease in the bone marrow. How much blast do they have? The second challenge is study design or population. Who are we including in these trials? The original clinical trial, which was compared to conventional care or supportive care, offered the azacitidine to patients who are higher risk. That technically includes people that are intermediate, high, and very high risk. And one of the challenges is that if you're picking a drug that can only do one of the two things, which is get rid of blasts or maybe kind of modify the stem cell compartment, um, if you include patients across the spectrum with intermediate, high, and very high risk, that's a pretty diverse population. I would argue that if you're dealing with drugs that are active in AML, like venetoclax, for instance, which has shown survival benefit and a very high remission rate in the setting of acute myeloid leukemia, you probably should not dilute your study with patients who are intermediate risk, patients who maybe would have been just fine with azacitidine, and we gave them too much drug by giving them a combination. But patients who are very high and high risk, that by itself means that they're more likely to transform to an AML that have the same functional phenotype. They probably would have benefited more from a combination. So one of the challenges is the study population, and that's part of the challenges we have with clinical trials in general. We do a lot of clinical trials with cooperative groups, national studies funded by the government, and the majority of the studies are funded by pharmaceutical companies because we need access to these drugs, and clinical trials are expensive. So often, to make sure we enroll at a reasonable pace so that trials don't take a decade to enroll, because you don't want the answer in 15 years, you want it now. The trials open up at many, many sites, which is good because it offers a diverse representation. But they often allow for a broad patient population where they include patients of intermediate, high, and very high risk, of all genetic mutations, and including of all blasts up to 20%. And even those without excess blasts. So maybe people with 0 to 4% blasts. And I would argue if you start including patients that have different types of MDS, you could dilute or miss a signal. And sometimes that happens when we're trying to enroll swiftly to a clinical trial to try to give patients an answer. So the study population is a challenge. A third issue is placebo. And many of the clinical trials, if there's a combination with azacitidine, placebo is given. And that's important because it allows us to treat patients without being biased on who gets what. So I think there's a lot of importance to placebo. But one of the challenges is if you have a drug combination where it's myelosuppressive, meaning the blood counts drop, then there has to be rules in the protocol about how to adjust the drugs when the blood counts drop so patients don't get bleeding issues or have infections or develop fevers. That part is really important because the quality of life for patients and hospitalization rate needs to be as low as possible. But if a combination causes the counts to drop and one of those two drugs is a placebo, we can't just drop the dose of the placebo and hope that the patient's blood counts improve. You have to actually drop the dose of the control arm first or the control drug first. And when that happens, you could be compromising the efficacy or activity because you're overall reducing part of the package, And so when you have a placebo in a myelosuppressive regimen, there is an inherent issue where you could be underdosing patients. If you already knew what drugs were being given, you could just adjust the right, either azacitidine or venetoclax or azacitidine and magrolimab. You could adjust one of the two drugs if you knew which drug you were dealing with. But when placebo is involved, that is an inherent issue that you could end up underdosing patients, which is often why in the phase 3 setting, the response rate looks to be lower than it is in the phase 1b setting. And then lastly, I would say it became the standard of care after the BMT-CTN 1102 clinical trial. That was a national study that confirmed what a lot of us already were suspecting, which is that the standard of care for high-risk myelodysplastic patients is not azacitidine. It should really be transplantation if someone is transplant eligible. And that clinical trial demonstrated a very large leukemia-free survival benefit if patients underwent a bone marrow stem cell transplant. Bone marrow stem cell means the same thing. And so in clinical trials over the last several years, as that data emerged and was published, there has been an appropriate gradual change where patients were now being referred for transplantation. And instead of patients just staying on the clinical trial, they were then consolidated or moved on to transplantation regardless of response as soon as a donor became available. And that is the right clinical thing to do because we know transplant's associated with cure or long-term remission. But you can imagine on a clinical trial, if that's not being monitored and the frequency of patients going to transplant is all over the place, it could change the expectation for what your original stat design was for how long a patient's going to survive. And that then can impact achievement of the primary endpoint. So there's a lot of moving variables, but those have been some of the conundrums that we've faced in the phase 3 setting for high-risk MDS.
Yeah, it's always so incredible to hear just how much goes into really putting together a quality clinical trial. So just incredible amounts of work, and thank you to you and everyone in the field who has helped get us to where we are and really being able to run effective clinical trials. I did want to ask what some ongoing phase 3 trials in high risk MDS that are exciting.
Yeah, there's some ongoing phase 3 studies. One of them is the Ascentage is a company that has the next generation BCL2 inhibitor. So it's like a better venetoclax, presumably. It's called lisaftoclax. It already is approved in China for lymphoid malignancies, has activity in CLL, where BCL2 is a genetic predisposition, meaning an inherent vulnerability. And so that study looks very much like the Verona venetoclax trial. So since it's supposed to be a better BCL2 inhibitor, there, and what I mean by that is there's faster activity, potentially deeper responses. They're looking to see whether or not that is the way to improve the combination approach with a BCL2 inhibitor, and they're going to see if they could get an improved overall survival. The one challenge to that study is they are enrolling the same types of patients that I just mentioned are kind of difficult to control, meaning they're including intermediate risk. They're including people without blasts. And so my hope is that they are able to enrich the study for patients who are truly higher risk, who really need that second drug that's active like it is in AML. And then there's also drugs like bexmarilimab, that's a Clever-1 inhibitor. It blocks Clever-1, which is found on macrophages. Macrophages essentially eat up debris or tumor cells when they're active. Macrophages are a part of the immune system, and we've been trying to figure out other cells in the immune system, like within a patient, that could help to eradicate or eliminate tumor cells. It helps to potentially increase presentation or awareness of these MDS cells to the immune cells within the patient, so that drug is acting biologically. So that I think the drug is super interesting biologically. We'll see whether or not it has significant activity in the combination setting. Um, I do see there's a question in the chat, Dalton, if you want me to go ahead and move to ask that.
Yeah, sure. I'll just read it out loud so everyone can see it. Can you tell me your thoughts about HMA before a scheduled transplant?
Yeah, I would say there has been no clinical trial that's prospective. Prospective means it happens in real time that demonstrates cytoreduction, getting the blast down, improves overall survival. However, there's a bias there. We don't transplant people if they're actively progressing. And so, on the old clinical trials that the Germans had run well over a decade ago, they tested azacitidine and they found that some patients ended up not going to transplantation. They got too sick from the drug, and then they found that there was no benefit in survival. We have since then also done what's called retrospective studies. That means that we have patients that we know how they did. They went to transplant. We know their survival status. We know if they got treatment before transplantation. It also looks like giving treatment before transplant does not help in that setting. But again, that's biased because patients already have made that decision and the transplanters have decided who they're going to transplant. So I don't think we have fully answered this question. I could just tell you practically what the challenge is. So when someone meets a transplanter, it is never been the case, and someone could correct me if I'm wrong, as far as I know, and for what I've learned over the last 15 years, no one could go to a transplant in the next couple of weeks. In general, it takes on average about 3 months. If your insurance is fabulous and you have a donor that's a sibling who's otherwise extremely healthy, maybe 2.5 months, but most people it's about 3 months. And so the challenge is when are you meeting the patient in their MDS course? What is their blast status? And what are the disease genetics? And what I'm saying is, when we meet a patient at MDS, like in the hematology world, when I meet them, I then refer them to transplant. Transplant, for instance, like it's the end of May. It won't happen until the end of summer. What do I do with the patient until then? So it depends on what their blast genetics are, blasts and genetics, so I know how the disease is going to behave. Because what's going to happen if I do nothing and just watch the patient, like I have them come in for labs just to make sure they're okay. We have to repeat the bone marrow about a month before the transplantation happens. And if their disease is exploding, that transplant is not going to work. And so we just remove the immune system from somebody who is not going to benefit from transplantation and wasted the donor cells and then put the patient at risk because now they're going to be at risk for graft versus host disease and infections. And their chance of cure drops significantly. Now, not all patients are going to be in that state, but we just won't know which patient is going to be progressing or which one will transform to AML. So we at least use genetics and the baseline blasts, and we'll use disease kinetics to make a decision on is this disease going to misbehave? And if it is, I would say I tend to, because I have there's a selection bias for the patients I see since I'm at a major disease center. They're being referred from other cancer clinics, so they've had other primary tumors, or they're being referred after an initial evaluation from the community. For MDS, I'm seeing patients that are sick at baseline and have been previously ill. And so it often is the case if I see blasts that are above 10%, or I see high-risk mutations that increase the chance of AML occurring. I will often give patients either a clinical trial for high-risk MDS or offer them a hypomethylating agent as a way to help to control the disease before transplant, not to get them into a complete remission. I do not require that. My transplant colleagues do not either. But I would say it is a common practice that we do not transplant patients who have 10% or higher disease because their chance of transformation to acute leukemia is high. And I guess maybe I could talk a little bit about transplant with that segue, just to give people background. Transplant is when we take stem cells from a donor. Stem cells are found within the bone marrow compartment. We have stem cells that are there from the time of our birth, and the age of the stem cells are our age. And so, when possible, we love to get stem cells from patients who are young and healthy because they've had less time to have things happen to them because those stem cells are younger. We can take patients who are donors up to the age of 40 and sometimes older than that as well, who, especially if they're related and we're having trouble finding donors. We have definitely done that because we want to make sure we get patients their best option. But stem cells are given to patients after they get a uh, conditioning treatment A conditioning treatment can include chemotherapy. Mostly it includes chemotherapy. In some countries includes chemo and radiation, but in US, the most common regimens are chemotherapy based. In the world, MDS tends to happen around the age of 70 as opposed to 20. There are plenty of 20-year-olds with MDS, but the average age is 70. And I mention that because there are two types of transplants that can happen. One is called myeloablative, and the other is called reduced intensity. Patients that get myeloablative transplantations are those that are less than 60 years old. Myeloablative means that they're getting a conditioning chemotherapy that is big gun chemo. So it's not a trivial amount, it's a lot of chemotherapy, and generally patients are hospitalized for at least 1 month. This is the type of chemotherapy where even the chemo on its own offers a significant amount of toxicity. And they have found when they give myeloablative chemotherapy to patients who are above 60 years old, it increases chance of death just from the toxicity of the chemo, and they haven't even benefited from the transplant in itself. So myeloablative approaches are given to patients who are young. The reason why myeloablative chemotherapy is special is because it also offers anti-leukemic activity, meaning it could get rid of MDS and leukemia cells. So when the conditioning chemo is given to a patient, the goal primarily is to eliminate the immune system of the patient. That way they can then accept the donor cells without killing them off. But when people get a myeloablative conditioning chemotherapy before the donor cell infusion, that myeloablative conditioning chemo is often potent enough to also contribute to the anti-leukemic process. So the way I tell patients when I meet them with MDS is their disease is up to here. We give them a little bit of treatment to bring them down to here. And transplant's goal is to eliminate the bad cells over time. It's not rapid, it's slow and steady. And so if you get a myeloablative approach, it offers you that added benefit of disease activity. And that allows patients to then undergo donor cell infusion, engraftment, new immune system. And that new immune system from the donor goes and kills off any leftover cancer cell because it recognizes the patient, but not the cancer cell, because the cancer cell should not have been in the patient in the first place. We have shown in randomized trials that myeloablative transplantations for MDS and AML improve survival compared to lower intensity regimens like reduced intensity. So when possible, patients should get myeloablative, but we cannot do it to patients who are above 60 because that starts to increase what's called non-relapse mortality, complications just from the chemo alone. So for the bulk of the patients that we see with MDS and that get referred to transplant, they will be recommended for a reduced intensity conditioning strategy. And that's the right thing to do. And that's because we don't want to hurt patients with just the chemo part when they haven't even benefited. If we are giving patients what we call reduced intensity or RIC transplant, which is the majority of patients again, um, that type of transplantation includes chemotherapy that solely eliminates the immune system or lymphodepletes. It does not contribute to getting rid of the MDS or leukemia cells at baseline. So that means whatever state I'm sending my patient a transplant in, that disease will continue to grow until the transplant benefits start to happen. What does that mean? So when people get a RIC transplant, the whole basis of the RIC transplant is the same as the myeloablative, where we are waiting for that donor immune compartment to get to work and start killing off any of leftover MDS or leukemia cells in the patient. But in a reduced intensity transplantation, to prevent patients from from rejecting donor cells, we give them immune suppressive drugs like tacrolimus, sirolimus. I'm just naming examples. And those immune suppressive drugs keep the donor cells from attacking different organs within the patient's body. But that's also keeping the donor cells in check, and it's allowing them to get used to what's your body. And this is a slow process. So the donor cells, the donor stem cells, will quantitatively engraft and recover and give the patient a white blood cell count, red blood cells, and platelets. But qualitatively, it cannot really kill MDS or AML for several months because you're on immune suppression. So when I take an older patient to transplant, I know the benefits of transplant will not happen until like month 6 or so. So that means that if I meet a patient with MDS, I know they're going to transplant in 3 months. the benefits of transplant will not happen 9 months from that time. And so I really have to be sure I'm not sitting on a powder keg. And so that's how I decide if someone should get hypomethylating agent or not. I use the genetics and bone marrow blast to give me some assistance to decide who needs a little bit of therapy. And I would say if a patient cannot handle hypomethylating agent, they can't handle transplant. So it's also helpful so we can get a gauge of what a patient's health is like. Are there other medical issues that need to be modified? But we're as careful as we can be without making patients too sick before transplant. But I would say it's often been very helpful for us to decide how we can improve the transplant setting for patients. Uh,
Wonderful. And um, I just wanted to, while we're on the topic of transplant, just to know if there were any novel opportunities to really help improve transplant.
Yeah, so that's another area of my research, and that's improving the ability to get patients to transplant, keeping patients from relapsing. Meaning, when I send my patients to transplant, it's really sad because I give them to another provider and I only see them socially, and visit them when they're in the hospital. But the idea is that they don't need me anymore because they don't have MDS or leukemia. And so, to keep it from being a revolving door where patients come back to me with relapse, I've been working on clinical trials to uh, eliminate minimal residual disease, meaning leftover disease, and improving the transplant approach by adding drugs to conditioning chemotherapy and by testing prophylactic maintenance to reduce relapse risk. So, as a specific example, we recently completed accrual to a clinical trial at Dana-Farber. It was like 102 total patients. Four separate groups of patients were studied, same types of patients, all high-risk MDS and high-risk acute myeloid leukemia. We allowed both patients. All of them got reduced intensity conditioned chemotherapy. We recognize that this is what the bulk of our patients get, but we did not like the fact that 60% of patients relapse. And if they have a high risk mutation such as P53, that's a mutation that everyone's a little bit nervous about because even with transplant by itself, survival of P53 can be as low as 20%. And that is, it's better than 0% without transplant, but again, it needs to be improved. So we allow patients with that mutation to come on study, and that represent about 60% of our cohort. So we let patients come on that had very difficult to treat disease. In that setting, we added venetoclax, the BCL2 inhibitor, to conditioning chemo. And then we offer prophylactic maintenance therapy with oral decitabine, with or without venetoclax. And I could just tell you that our expectations for infections were spot on. We did not think we would make patients sick, and that was true. Infections were very low. There were brief low blood count issues that recovered just on time for a cycle to be repeated. By giving oral therapy, patients were able to complete the maintenance therapy because it was less burden to them, less visits to Boston. And importantly, in our single arm study, meaning there was no randomization, we did see that the survival was really fantastic for a super high risk cohort. It was 77%, which I thought was really outstanding for a very high risk group where it was not expected to be like that, even if you included intermediate or other risk. We did not include patients that were not adverse risk. So I would say it was really impressive. And it told us that maybe there's an opportunity there. So we're doing the next phases, which is we're trying to develop the phase 3 studies to test, was it because we adjusted the conditioning chemo or was it because of the maintenance approach? And we're asking the question, and we have to randomize in that setting, which is the uncomfortable part, to prove and demonstrate that everyone should get X, Y, or Z drug.
Wonderful.
The last thing I will just say is uh, transplant has gotten better over time. We have better antifungal therapies, antiviral therapies to target CMV that used to be super common and where patients would get sick, not anymore, and graft versus host disease, which could be a long-term chronic and morbid conditions that can affect multiple organs. We have gotten so much better. It's not yet gone completely, but so much better at dialing down how much these complications of transplant have affected patients and quality of life. So that now means we could start focusing on the real problem, which is relapse, and how do we keep that from
Mhm.
happening? So we're in the right time now to be looking for trials and developing studies in this space.
Okay. I did want to address a question that came in from the audience. This individual says, "Thank you for your presentation, Dr. Garcia. My close friend is high-risk MDS, 15% blast in the stem cells, but none in the blood, with no identified mutations. Do you know of any research that may be happening in this sort of space?"
Yeah, thank you for that question, Vicky, and I'm sorry to hear about your friend. I would say a couple of possibilities. One is the mutation panel might not be extensive. So there are, like a set of 5 to 8 mutations that one definitely needs to get. But I'll just give you an example. At our institute, and we're super spoiled. I recognize that, we have access and we develop our own tools because we're a high volume center. We have 88 genes in our panel. So we're testing everything that has been associated and could be pathogenically linked to MDS. So I would say in our hands, well over 90% will, if you have MDS, well over 90% will also have a mutation found on our panel. For patients that don't have a mutation, they are likely to either have a chromosomal abnormality or abnormal cytogenetics or FISH. That's the chromosomes that make up that is filled with your DNA. And so major chromosome abnormalities could happen as well. The other possibility is there could be something called an RNA fusion. That's another type of molecule that we all have, and another type of expression pathway that's super important for how blood cells behave. And RNA fusions are not standard to get because they're not easy to find, but at dedicated centers, like we happen to have an RNA fusion panel that we run to look for hidden or occult fusions that could be drivers of disease. Those are super uncommon in the MDS space, but that is also possible. And I would say lastly, the one thing that it could be is there could also be germline cases. So if the chromosomes are normal and there's no standard somatic mutations, meaning spontaneous mutations or myeloid mutations, there could be a germline condition. And so there are mutations, for instance, one of them is called DDX41. It was under the radar for an extremely long time. It's an inherited or germline condition, which means someone was born with it. And the reason why it was under the radar for a long time is because when someone thinks something is genetic or germline or inherited, you think about a young person that developed way too many cancers at a young age that should never have happened. But in DDX41 cases, the presentation's in the sixth or seventh decade of life. They're presenting in their 60s or 70s, which is when the typical MDS patient who does not have an inherited condition presents. And so it flew under the radar for a very long time. And it wasn't until people found that DDX41, which is an important blood gene mutation, a blood gene, and when it's mutated in this dead box protein, it could lead to alterations in how the blood cells develop. And once we identified it was a germline condition associated with cases with throughout a family, we then started searching for it. So on our panel at our disease center, and many other large centers are doing this too. If you're not referring patients to genetics, we're including this. It's in my gene panel already of 88 genes. So I would say if you don't have a classic MDS mutation, it could be a rare germline condition as well. And like in an assay like the one we have at our center is called rapid heme panel, it includes DDX41, which otherwise would have been missed completely. And so I would say look at the extent of the panel, chromosomes, and then look for to see if there's an RNA fusion test. But um, uh, in general, there will be some sort of finding there. Whether it's meaningful or helpful to the patient is a separate question. But there are some rare cases where we don't find it, and that could be the depth or our ability to capture a mutation with the current tools available. There are limitations to some of our tests.
So, um, this has been so incredibly informative, and I feel like time is flying. We have just a couple of minutes left. So I just wanted to ask you if you, I guess, kind of final thoughts, or if there were any earlier phase trials that show biological promise for higher risk MDS, or anything that you want to touch on just before we have to hop off in a few moments.
Yeah, no, and thank you for your time and this opportunity to be available to patients outside of my practice. I would say early phase clinical trials is where the bulk of my work is in, mostly because that's the right time you want to really understand um, how a drug might work and who the right patients are based on mutations or other biological features or other biomarkers to make sure that we're giving it to the right patient and then move it forward to the mature phases of the clinical trial. But current drugs that are interesting, I'm just going to name a couple. One drug that we have heard about, and I think a lot of people here probably know about, are IDH1 inhibitors. That is already FDA approved in acute myeloid setting, ivosidenib and olutasidenib, and those have been tested already in myelodysplastic syndrome. And so there's ongoing trials with ivosidenib or olutasidenib on its own, or with decitabine, or in combination with venetoclax as well, to try to improve outcomes for patients with MDS. So IDH1 inhibitors are important, but they are currently only going to be tested in patients with IDH1 mutations, and that's less than 10% of MDS. So an uncommon subgroup. Um, Another drug that is super interesting based on the splicing biology, splicing mutations make up the majority of patients of myelodysplastic syndrome, and some data out of Memorial Sloan Kettering by Omar Abdel-Buhol demonstrated that click inhibitors could be really exciting and active in the myelodysplastic syndrome setting, whether or not you need a splicing mutation still being evaluated. But there's clinical trials with click inhibitors. One example is Sirtuviant. We have a clinical trial at our center, for instance, with that's being led by Dr. Evan Chen. And lastly, a drug that I am excited about because some of the science that came out of Dr. Andy Lane's lab at our center that was really exciting is the PI3 kinase gamma inhibitor, eganelisib. It's anticipated that there will be an MDS cohort for that in this early phase clinical trial based on some strong preclinical preliminary evidence of its activity in leukemia cells. And so I think there's a lot of room for us to improve the current standard of cares. There's a lot of exciting early phase clinical trials. They are not always open. So this is one of the things I'll just say about clinical trials. They have to be developed, they have to be funded, and then there has to be slots, and patients have to be eligible. All those things are moving targets. And so we are always improving and developing studies whenever we can. And many major disease centers will have MDS trials, but there won't always be an open slot because we often have to wait for a certain period of time after we enroll a certain number to make sure it's safe to then move on to the next cohort. And that process just needs to happen because we need every patient to be safe, to understand a safety signal, to understand if how the drug is working and how to give it to patients safely. So I would say there's some patients that clinicians need and patients need in that process too. And we're always trying to do our best because patients need stuff now. But I would say there's a lot of efforts to try to improving not only the transplant setting, but drugs for patients with high-risk MDS. And for us to further, just to get back to, I think, Thomas's question, figure out who needs therapies in advance and what therapies could be safely given so we could still transplant our patients safely. One opportunity there might be is if someone is not treated, they then go to a transplant study where they're offered maintenance. So they continue, it's called continuation of therapy at the time of transplant until the benefits of transplant occur. So that could be an area where maintenance could be very helpful as when patients are not treated in advance.
So this was just incredible. You truly did such a good job of answering all of these. And just thank you so much for your time. We are going to go ahead and wrap up just because we are getting to the top of the hour here. Um, Speaking about clinical trials, I did want to let everyone know that HealthTree does have a clinical trial finder. So it can help you find clinical trials that you may be eligible for. So if you are interested in exploring clinical trials, highly recommend checking it out. It's just a helpful tool that can kind of take away some of that legwork and make it a little bit easier to find trials that you could be a candidate for. But just wanted to let everyone know about that. And then I also wanted to give a shout out to our Black health community here at the HealthTree Foundation. This is a dedicated space for the Black community to really come together and share their experiences. So just wanted to help let people know that this is out there in case anyone would be interested in joining. And we do have a couple of upcoming webinars that I think our community may be interested in here. First up is a community gather event that we will be hosting next Tuesday, or sorry, that should say webinar. This is a financial webinar for the rollout of a new financial assistance program for cancer patients and how it can benefit you. Next Wednesday is Gather. I've got those swapped. But I have a MDS and CMML community gather connecting from the comfort of home. So this is a space for MDS and CMML patients to come together and share their experiences and speak with others who truly understand what they're going through. And then on Tuesday, June 9th, I have Expert Care Anywhere, how telehealth can help you navigate your care. So some really good upcoming events in the next couple of weeks. So I hope to see you all there. And finally, before we hop off, just again, a big thank you to everyone for joining us today. Thank you to Dr. Garcia for spending so much time speaking with us and covering so many different things and doing such a good job of it. Very easy to follow along with and just very well done. So, I have my email up on the screen. It's just Dalton, Dalton at healthtree.org. Please feel free to reach out to me if you have any questions. I'm always here to speak with members of our community. And with that said, I hope everyone has a fantastic rest of your day.